Hello, greetings to all the Physio TV viewers. Today, as usual, Physio TV is bringing one more enlightening talk, and the speaker for today is Dr. Khyati Shah. Dr. Khyati Shah is a bachelor's in physical therapy from the ES College of Physiotherapy in Pune. She's a master's in physiotherapy from the Rangunwala College in Pune. She's presently a master's in research of spinal pain at University of Birmingham in United Kingdom. She's also been an alumni as a clinical staff at Sancheti Institute of Orthopaedics and Rehabilitation. She practices manual therapy, taping, neurodynamics, myofascial release, Mulligan, as well as soft tissue mobilization. Ma'am has been a musculoskeletal therapist, and she was even working with us as a musculoskeletal therapist. And presently, she's gone for further research studies to the UK. We welcome you, ma'am. So today's talk by Dr. Khyati ma'am is going to be on improving the functional outcomes after ACL injuries. After ACL injuries, we do hear a lot about rehabilitation, which is done, the phases of rehabilitation. But we now need to look and inquire a little further about how do we go about improving the functional outcomes post ACL injuries. So I would take this opportunity again to welcome Khyati ma'am and to enlighten us on this very relevant topic. So welcome and giving the session over to you, Khyati ma'am.
Thank you, Sona ma'am. It's always a pleasure to be a part of the Sancheti platform and OrthoTV and PHYSIO TV to deliver these seminars, as these are all very evidence-based, and it keeps all the students and clinicians updated about the recent techniques going on. So it's a pleasure today, and I'm thankful for this opportunity which I got today. So I'll start with the topic, which is improving functional outcomes in ACL injuries. So good afternoon, everyone. And this is Dr. Khyati Shah. I'm a physiotherapist, and I'll be talking today on the Sancheti platform regarding improving functional outcomes in ACL injuries. So next slide. So as we all know the anatomy of the anterior cruciate ligament, I'll not go into the details about it because today we are focusing more on the outcomes and the rehabilitation novel techniques. So as we all know, anterior cruciate ligament injuries are very common and they occur quite often. Even after rehabilitation, there are chances of re-injuries. So that's what our main focus is today, that what outcomes we should choose so that we can reduce or prevent the chances of ligament injury. And as we all know, ACL is a devastating knee joint injury, which leads to short-term disability, leads to occupational discomfort, like athletes who have to refrain from playing. And it also has some long-term sequelae, like osteoarthritis. So as it is mentioned, due to high risk of long-term osteoarthritis in treatment population following ACL, the effectiveness for this life-altering knee disruption disease, for this knee disruption condition is to prevent it. So the main focus should be on prevention. So the mechanism of injury, as we know, it is a pivotal injury which involves translation and rotation in all the three planes, that is the sagittal, frontal, and the transverse plane. Mainly seen in athletes having cutting, running, and crossing type of techniques in their sport. Example: rugby players, soccer players, badminton, or football. So the movement which is involved is a dynamic knee valgus, which leads to excessive hip adduction and internal rotation, as we can see in the figure. Also, we can see there is tibial abduction along with anterior translation of the tibia in the sagittal plane, and also there is eversion at the ankle. So it is the whole lower limb kinematics is affected. So it is a dynamic valgus force. So and so it can be quite acute and sudden. So next slide. So the main factors which we should focus on are the risk factors, which include gender and hormonal variations. I'll elaborate on all of them one by one. So gender and hormonal variations, maturation, laxity, neuromuscular and biomechanical risk factors, which are the only modifiable risk factors of all of these mentioned here. Any previous injury and genetics. So as we all know, female are tenfold times more prone to ACL injuries or ligament injuries in general as compared to their male counterparts, which is proven and has evidence in all the studies which are done to compare the risk of injury in male and female athletes. So as we all know, there is gender variations due to neuromuscular factors, biomechanical factors, hormonal differences, and the anatomy of the male and female counterpart. And it is also known from the systematic reviews that after onset of puberty, the genders differ in hormonal milieu. That is, there is also an article which states that menstrual cycle is associated with increased knee laxity and ACL injury. So that is why females are more prone to ACL injuries, because after puberty, the male and female athletes or the male and female counterparts, they demonstrate divergence in their hormonal and neuromuscular factors, which leads to more injuries in females compared to the males. Also, I'll elaborate more on the maturation, which says that prepubertal children, they do not exhibit any sex differences in lower limb biomechanics and neuromuscular differences. So before puberty, the male and female have the same neuromuscular and anatomical factors. It only changes after the puberty, which leads to more of dominance in the female, like leg dominance, ligament dominance, trunk dominance, and quadriceps dominance, which I'll elaborate in the next slide. But and any previous injury, as we all know, if there is any previous injury in the knee, it makes the ligament more vulnerable to further injuries. And genetics has a partial influence in ACL risk factor. So next slide. So in the prevention techniques, the only out of so many evidence, there is still not a very clear view of which is the ideal prevention technique. But of most of the systematic reviews found, it is seen that integrated neuromuscular training program, which includes biomechanical feedback and control, like the landing technique, the cutting technique, the running technique, which has to be perfectionized. The neuromuscular control also includes core control, posture, proprioception, and strength training techniques, which has proved to enhance performance and also have motor adaptations and learning adaptations in the brain. But as we all know, the rehabilitation of ACL is a very long rehabilitation, usually requiring 6 to 8 months before the athlete can go to return to sports. But even for a sedentary type of individual with ACL injury, the compliance of the treatment is needed for any kind for prevention of the techniques. Like he still has to do 6 to 8 months of rehabilitation to prevent any long-term damage. So next slide. So the main part, as I mentioned earlier in the risk factors, which correlates with this, is the timing of intervention. So after puberty strikes, like pre-adolescence or early puberty, seems to be a critical phase for increased ACL injury risk in female athletes. But after the onset of puberty, they start demonstrating differences in laxity and in the neuromuscular control, which leads to divergence in the injury rate of ACL. So as I mentioned earlier, neuromuscular training is currently the only effective tool for lowering the incidence rate of ACL injuries, which has a direct link to reduction in the post-traumatic osteoarthritis. So next slide. This is from an article of which the reference is given in the ending of the presentation. This is an injury prediction nomogram, where these are the factors which we have to look for when we are trying to assess or screen the participant for the ACL injury risk. So the points which are mentioned are tibial length, knee valgus motion, knee flexion range of motion, then mass of the person, then quadriceps hamstring ratio, which we have all learned it throughout, that it has to have an equal firing rate. Like if it is less in either of the one, it leads to more risk of ACL injury. And then you have to calculate the total points according to the injury prediction nomogram. And you can calculate the risk of the participant or the individual who is prone to more injury as compared to other counterparts. So next slide. Yeah, so this is a very interesting slide where you can see that I'll explain one by one what is ligament dominance. Ligament dominance is when your muscle function is poor and it is not able to absorb the load which is put during the playing movements. So the load is absorbed more by the static components, that is the ligaments and the joints, which is why it is called a ligament dominance. So you can see when there is ligament dominance, you see valgus at landing. So these are the factors which you have to make a note of when you are screening someone, to check out what kind of injury factor is present. So for ligament dominance, as you can see in the diagram, there is valgus at landing, and the foot placement is not shoulder width apart. And quadriceps dominance, as we all know, quadriceps dominance, the definition of which is the stabilization of knee is extensively done by the quadriceps, and there is no balance between quadriceps and hamstring, which is why quadriceps dominance is also a risk factor. And as you can see in the diagram, it leads to excessive landing contact noise, like especially during jumping activities or during agility activities. Then in the next one is the leg dominance or residual injury deficit. As I had mentioned earlier, till puberty, there is no gender differences in the lower limb biomechanics. But after puberty, when the female athlete or the female participant tries to do side-to-side movements, which is required in some sports, so female counterparts tend to use more of, they are dominant more with their one leg compared to both the legs. So that is why they also have this leg dominance, which makes them more prone to injuries. Also trunk dominance, which is due to core dysfunction. So as you can see in the slide, the thighs do not reach parallel. So there is more movement from one side of the trunk compared to the other, which means that the trunk is not flexible or does not have good core strength to move in the three-dimensional plane. So there is more movement from one side of the pelvis as compared to the another one, and it does not land in the same footprint. As you can see, there is hiking on one side and there is downward tilt on the other side, especially when it comes to vertical jump test or any kind of running or jumping activities. And as we know that practice does not make perfect, but perfect practice makes perfect. So technique perfection is declined just 10 seconds before the actual movement has to be done, which also leads them to more injuries. And this is all more prone in females as compared to males. So now, next slide. So this is a good study, the article of which I have put in the reference. So the successful outcome measures, according to the Delaware Oslo ACL investigation, which was done in 2013, shows that the first six mentioned outcome measures are, according to the consensus, the most successful outcome measures, as compared to there are many other outcome measures as well for ACL injuries, but these have been proven to be more successful. So the first one is the absence of giving way, which is the most common thing which you can experience in a patient with ACL injuries. So that is the absence of giving way. Then the patient return to sport status if he is a sport participant. Then the absence of knee joint diffusion, because ideally it is an acute stage thing, the knee joint diffusion, but if it pervades or it prevails, then it is also an outcome measure. And quadriceps muscle strength symmetry, as we had already discussed, hamstring muscle strength symmetry, and patient reported outcome measures, which is visual analog scale for pain, then Leisholm knee scale, International Knee Documentation Committee, and Cincinnati knee scale. So these were the patient reported outcome measures used as a group, but it is also mentioned in the same study that if it is used individually as an outcome measure, then the patient reported measures are not very valid. So ideally, if you are using the patient reported outcomes, they should be clustered together, and you cannot just rely on one outcome measure. And even though ligament laxity and osteoarthritis is quite common, but it was not considered according to the consensus as an important outcome measure to be taken note of. Next slide. So as we all know, the rehabilitation techniques, like I will not be going into the mainstream techniques, which we all know, like strength training, proprioception. These all, we all know that we do it in the rehabilitation, the price treatment, which is in the acute phase. But I'll be guiding you with the more novel rehabilitation techniques, which you can incorporate in your routine physical rehabilitation, because they have proven to be more challenging for the athlete, and it gives good long-term results by having neuromuscular adaptation in the brain as well. So I'll explain all the techniques one by one, how it helps in the rehabilitation and guidance of the ACL rehabilitation. So with motor relearning, as we have seen in neurological cases like stroke, it helps to support neuroplasticity. One of the main drawback of the ACL treatments which we do is that there is no neuroplastic development in the brain. Like there is no, if there is no permanent changes in the brain after rehabilitation, it can again and again form the same incorrect patterns, and again it can lead to more injuries. That is why we see, if it is not treated holistically, there is more and more chances of ACL injuries occurring again and again. So motor relearning is a very important aspect. It can also, it helps in improving functional performance and reduces the risk of second injury. The key concept how motor relearning helps in the rehabilitation of patient is by external focus of attention. Like when you are doing a task, if you are attentive, you can have more blood supply to that part of the brain, and it can lead to good interneuron connection. So it helps by external focus of attention, implicit learning, contextual learning, self-controlled learning, and differential learning, depending on the setting of the rehabilitation. And it helps by challenging the neural network. Then the second one is guided imagery or mental imagery, which is proven in the article which I've mentioned behind, like when you use the mental imagery in combination with physical exercise, it is more efficient than compared to the physical. It is more efficient than physical exercises alone for strength training. So this helps. So this guided imagery is a very useful technique if you use it during the acute phase of rehabilitation, when the patient is usually in too much pain, and sometimes the patient has to be immobilized. So it helps in preventing the short-term strength loss, which comes with the functional bracing, or which comes with the immobilization. Also, it is proved that imagery is linked to motivation and self-efficacy, affecting neural adaptation and strength performance. So, example, mental imagery when checked with EMG activity showed increased activity when you imagine the participant to lift a heavy object, when compared to when you tell the participant to imagine a light object. So when you tell the participant to imagine lifting a heavy object, it was found that there was more EMG activity in the muscles which were active. So it works more for muscles like active movements and not passive techniques. Like you have to ask something dynamic to imagine. And also it helps in neural adaptation, like motor relearning, stronger brain activation, sensory motor activation, and physiologic responses also increase, like heart rate, blood pressure, and respiratory rate. So it helps more with the blood flow to the imagining area. Then the third one is the Pilates and the Tai Chi technique. As we all know, Pilates is more of core control, and Tai Chi involves varying speed of movement and holding the poses for a specific duration of time. So both of these leads to good core control and good body posture, which helps in optimizing the task which you have to train the participant to do. Also, it was found that it decreases pain. Pilates and Tai Chi both were effective in decreasing pain. Tai Chi to a higher extent decreased pain and also increased the proprioception. Both the techniques are proved to be increasing the peak muscle torque as well. So though they had no effect on the patient-related outcome measures, it helped in strengthening of the muscle. The mechanism by which it works is the presence of resistance type of movement, which provides enough load to increase the blood flow in that area and to increase the strength. Then the neuromuscular training, as we have spoken about it earlier, neuromuscular training involves multiple types of activities in the same combination, like balance, proprioception, strength training. Example, by doing a single limb squat or a vertical jump, or if you do squat training, squat jumping. So these involve like plyometrics or plyometrics agility. These all are part of the neuromuscular training. So, but the main thing is not just training, but training effectively, because training in correct patterns and not focusing on the techniques like the ones which I mentioned earlier in the slide, like about the leg dominance, ligament dominance. So when you're doing neuromuscular training, it is important to screen all these types of altered movement pattern. So there is one more effective rehabilitation, which is not used quite often, but has proved to be very effective, which is biofeedback technique. So as it is mentioned in the articles, it is seen that EMG biofeedback, when given for 6 to 8 weeks in early phase of ACL rehabilitation, is useful in increasing knee extension strength, that is the quadriceps strength, which helps in maintaining the quadriceps to hams ratio. So how does EMG electromyographic biofeedback help? So it is by improved innervation of the vastus medialis muscle, which plays a key role in developing knee extension strength And also it is simple, inexpensive, and a valuable adjunct. Because when you are doing a biofeedback technique, the patient has to be alert, attentive, and he has to be more aware about the movement pattern, which leads him to do. And as he can visualize the electromyography in front of him, he's more aware and he tends to do more correct muscle activity. So you can see if he's activating the vastus medialis during the task which he has to do. So it is related. So EMG biofeedback helps by increasing performance, which is equally linked to the motivation of the participant and the self-efficacy of the participant. Also, one important thing which sometimes not all clinicians take note of is open skill versus closed skills training, in which open skills is practicing in the actual environment and closed skills is practicing in an artificial setup like in a rehabilitation department. So as we all know that the shoes of the participant, the ground or the surface where the participant actually plays, the climate of the place where the participant plays, these all are very important factors when they return to sports. And if they are not trained in the actual setting, there can be chances that even if they are doing it the correct technique, they have not practiced it in the actual environment, because with closed settings or with the closed training, the participant is in a protective environment which does not challenge his actual playing conditions. So it is important that few of the techniques like agility, cutting, plyometrics can be done in an open environment as compared to a closed environment. Next slide. So as we can see in this, dynamic neuromuscular techniques, which include plyometrics, single limb balance, and perturbations. So you can use or combine most of the activities depending on how challenging you want it for the participant to be. Next slide. Yeah, so in this slide, you can see that there are markers placed all around the participant, which gives them training on what he or she has to activate during running, like the adequate or ideal posture which is expected during running, like the elbows should be 90 degree, the head should be neutral, there should be slight anterior pelvic tilt, more of knee flexion, and there is more of plantar flexion. So these are the things which the participant can make note of if we give them visual biofeedback, and we can train them according to the markers placed in this article. Next slide. So this is the electromyographic biofeedback. Like if you are asking the participant to do a single limb squat, he can stand in front of the mirror, as well as he can see on the screen in front of him the activity of his muscle which he is recruiting. Like if he is recruiting more of lateralis, example, instead of the medialis, it is seen that with the biofeedback, he can alter the activity pattern, and it can lead to more blood flow and innervation in that part of the muscle which is more active. So with these novel techniques which should be incorporated, it can lead to good brain neuroplasticity and help in improved motor performance and motor learning, which can also improve sensory motor control, which helps in overall holistic development and adequate rehabilitation of the patient, preventing his chances of injury in the actual performance setting. And these are my references. And still, if anyone needs to know any more information, they can anytime contact me, and I'm very happy to share any more articles which I have. So thank you for listening, and it was a great pleasure to share this knowledge with you.
So it was a very interesting talk. I think there were many pointers that we kind of learned about improving functional outcomes, right from what are the risk factors, what are the modifiable risk factors which we should be working on. So,
Yeah,
and also about the injury prevention nomogram. So that also was a
yeah,
very interesting, concept which was taking into consideration so many of the values and how they add up to, either making the athlete more prone towards injuries or how he
yeah.
can
So you
avoid
can use it
injuries.
as a screening assessment, and also
Exactly.
about the like the dominance, which is prevalent in so many cases. So when we are
Exactly.
training the participant, it is a good screening technique to see if they are landing correctly, if they are, cutting correctly.
Yes, yes. That's true.
Yeah,
I mean, that's what, right from the pre-risk factors to what actually exists. And plus, of course, about how you mentioned about the leg or the ligament dominance, the quads dominance, the trunk dominance, as well
yeah,
as, the technique perfection, which is needed. And
yeah,
even perfecting the skill in a very open skill environment
yeah,
rather than the
yeah.
closed skill environment. I think that
Yeah,
that really
because
is
that
important
I
because there
think
are
is a
many.
very
Yes.
contextual factor, which
In
not
fact, most of the
yeah,
rehab is moving towards that. I hear many people telling that most of the rehabilitation now, at least about the final lab, should take place, more in the place where they practice rather than, their sport, rather than taking place in a physiotherapy OPD. So once we know
yeah,
that, we have developed their muscles or we have got the range or the mobility required,
yeah,
the balance and the proprioception has come back, then as we move towards the last lap, of our return to sport, as they call it should get more into the open skill environment rather than the closed skill. I think that's
yeah,
again
and
a
it
very
is
nice
especially
point.
important for the sports players because it like their career depends on the
Exactly.
rehabilitation which they have done. So
Exactly.
which overall has a psychological and a holistic impact on them. So
Exactly. And also
so
wearing the shoes that they wear, being in the
yeah, the
environment that they
surface
are.
on which they play,
Exactly. So
and
that
also
brings
the
value.
climate, because the physiological changes around the environment where you are playing, like if he's from a tropical environment and if the setting of the lab is not very tropical,
Hmm.
it makes a difference in their physiological responses like heart rate,
Exactly.
vasodilatation.
Yeah,
Yeah,
true. True. So that again, that's what I'm saying. So even the markers which you mentioned in the end, about how the placement of the neck, the elbow should be when we are kind of, training them for their
yeah,
actual sport or whatever. So I guess all this adds up to the fact that, there's a lot we can do. As you mentioned in the modifiable risk factors, the biomechanical and the neuromuscular part, is very, very modifiable. Even
yeah,
if we can't change the genetics, the gender, and other factors, this is something
yeah.
that we can really work upon. And that's where the strength of the physiotherapist also lies. So I
Yeah,
guess
and
we can go
there
a
are
long
these
way.
novel techniques like EMG biofeedback, which
Exactly.
leads to more enhanced performance because the person
Even
can see the
awareness.
activity of the muscle himself, which he's
Yeah, even
recruiting.
the awareness of
Yeah,
what really is happening. So if you give them a feedback about what really needs to fire and at what time and how much
yeah, yeah.
proportion, I guess that kind of improves, again, goes a long way in improving his functional outcome or her functional outcome.
Yeah, exactly.
So,
And because if you train the symmetry of the recruitment, it helps in more innervation and blood flow in that part of the muscle which you want him to recruit. Like as we all know that to have effective knee strength, it is important to train the vastus medialis. So when the person can see that he's recruiting more of lateralis, you can give him feedback and you can change the activity of the medialis to lateralis ratio. So that is how biofeedback is very effective. Because here
that's very
also,
interesting.
like when we practice it in this setting, I have seen that it really works well.
I'm sure. I guess you're given a lot of points to all our listeners to ponder upon and maybe build their base about improving, ACL outcomes. I
Yeah,
guess right now we kind of have a base of most of the management, but we should move towards improving functional outcomes in whatever we do. So I had heard a quote said by someone that it has to be cheaper, faster, better. So that's where we should be moving towards.
Yeah,
So that's
exactly.
where our
Because
rehab should
today
move.
everyone, because all the healthcare has become quite expensive. So you have to work towards more ecological aspects where,
Exactly.
like this is very simple and inexpensive, and it should be easy for the patient as well to use it, and not
Yes.
just for us.
Yes, yes, yes.
Yeah.
So all in all, ma'am, I would like to again now from the entire Physio TV team, I would kind of like to thank Dr. Khyati Shah for giving a very enlightening talk on improving functional outcomes. I'm sure the clinical pointers that she gave is going to help us to rehabilitate our patients much better following ACL injury or ACL repairs. I would always like Khyati ma'am to keep coming and taking more such entertaining and enlightening talks for us and for our viewers. And with that, I'll be kind of signing off. Thank you so much, ma'am, for this wonderful talk.
Yeah. Thank you, Sancheti Hospital, Sancheti College of Physiotherapy, and the Physio TV platform, which always gives me opportunities, and I'm glad to take them. And I'll still
Always a pleasure.
feel like a part of myself being there.
You are always a part of our team. So thank you
Yeah.
so much, Dr. Khyati Shah. And I would also like the technical support given by Dr. Tushar. So a big thanks from the entire team